my pleasure to introduce Dr. Sonny Dhanani. Sonny is the chief of the Pediatric Intensive Care Unit at the Children's Hospital of Eastern Ontario in Ottawa, and he's also Associate Professor of Pediatrics at the University of Ottawa. He was recently the Chief Medical Officer for Donation at Trillium Gift of Life, and now I know he's involved on the research side with Trillium, and he's the chair of the newly formed Canadian Donation Physicians Network, and he's the vice chair of CBS's Deceased Donation Advisory Committee. Then the CNTRP, Sonny is the co-lead of CNTRP Project 2, which is all focused on donation. And his particular study that he's focused on is called the DPART study, which you're going to hear more about today. So at this point, I'm going to turn it over to Sonny, and I appreciate everyone's participation. And thank you, Sonny, for giving this presentation.
Thanks, guys. Thanks for joining, everybody. I know I'm looking at the list here. I know there's a pretty broad range of individuals. Because I had some experience with the CNTRP training program at the beginning, a lot of your names are very familiar, and I'm really excited that you've joined. I'm hoping this will be relevant to all of you, even if you're by the bench or more on the transplant side than the donation side. And if things are unclear or you need clarifications, I'll stop a few times to make sure that we have an opportunity to discuss. This slide has our core group, but I'll mention later how big our group has become. Laura works out of Montreal, and Amanda and Nathan and Melanie work here in Ottawa. Sam Shemi is a leader in donation over the last 20 years in Canada and internationally, and very respectfully have to hand it to him to guiding our project and myself along the way. I'm the little guy in the corner here. I probably could have shaved for that picture, but didn't. And I'd like to tell you a little bit about our research program, if I can move the slide. Now, of course, kudos to our collaborators. None of this work would have been done without the CNTRP, and I think you guys are well aware of the amount of work that happens amongst the 7 projects. I know you guys have presented on our behalf and been at the conferences. Excuse me, so you've seen the wide spectrum. But, you know, this is a collaborative across Canada, and I think that's really the most important part here. And then rather than focusing on the details of the study, to make it relevant to all of you, change the objectives a little bit to kind of go through what I've learned over the last 10 years as developing this research project. To one, make sure that when people say that it can't be done or that isn't a great idea, that you make sure that you stick to your guns and keep working at it. And to do that, make sure you collaborate. I know early in my career I was very nervous about getting scooped by smarter individuals that worked faster, maybe with more money. But in fact, the only way that I've gotten through this is the collaboration. And now I'm seeing some of the participants that have joined on the call. These people have helped me along the way. And that what stressed me out initially is that I had an initial question, but really realized that that initial question and now has blossomed into many other questions. But really we need to embrace that. So I hope those are the things you take away from this talk at the end. A little bit of background. In 2006, this family, the Tyrians, came to their physician, their critical care physician in Ottawa, excuse me, and after their daughter was critically ill and dying, they asked whether their daughter could be a donor because they had had the conversation yesterday. And in fact, Sarah Beth at that time could not have been an organ donor because at the time we were only able to donate organs after one had fulfilled a very strict set of criteria that allowed them to be declared colloquially brain death, neurologic determination of death. And that happened very rarely. Only 3% of all deaths in Ontario at the time in a hospital, and this is a lot of deaths, were eligible. So in fact, they were told no. But in fact, they pushed, and there were new protocols, Canadian protocols, in fact, that were coming out that said you could do donation after being declared circulatory death, meaning you didn't need to fulfill all the brain death criteria, but you had another opportunity. And in fact, what's happened in Ontario is that it wasn't a new era, that now by 2017, now 2018, that in fact DCD, donation after circulatory determination of death, is a standard of practice. It's still the same type of patients, a non-recoverable injury. They're on mechanical support in an intensive care unit, but they don't fulfill all these brain death criteria. I won't go through the details of this, but these individuals are almost dead, and in fact the recommendation is to withdraw life-sustaining therapies so that they will be imminently dead. Now in Ontario and in most provinces, that these individuals can donate. So it seemed, actually, when we looked at the numbers over the last decade or so and split them up into eras where before DCD, around 2006 where we just started DCD, and then most recently, kind of 2014 where it was established in Ontario, that we were seeing that donors from DCD were substantially increasing the overall number of donors. And in fact, that meant that our transplant rates were significantly higher. So it seemed like a pretty simple task to get everyone on board to do DCD in their environment. But in fact, there were some controversy. Because the brain death criteria were so standard and an objective sign of death, and we were declaring people ahead of time to then become donors, that there is a more subjective nature of making a decision to withdraw life-sustaining therapies first. How would that be done? And in fact, what we realized was there is now an issue of declaration of death. And I'll go through why that was an issue. So when we look at what death is legally, it's pretty loosely laid out that physicians must be present. Well, that's good. And that death shall be determined by 2 physicians. That seems pretty standard. But in fact, then it's left up to accepted medical practice. So there weren't strict criteria. And in fact, I'd say to you that it's always been safe, because if you're dead this second or in half a minute or a minute later, you will most certainly be dead once that decision to not resuscitate is placed. But in fact, for donation, it becomes different, because we rely on something called the dead donor rule, where one must be dead before donation, and that the act of donation, say the removal of an organ like a kidney, can't cause or expedite death. So that means you have to be dead before you donate. And I'll reflect back with brain dead donation that in fact we had strict criteria to declare someone dead before donation occurred, but now with DCD, we needed to look back and see if we could structure our process to make sure to ensure someone was dead before that happened. And really this principle is based to ensure trust within the organ donation system, that we have clear parameters of practice. This isn't just for the medical community, but I think it's just as important for everyone, including the public. Now, if we don't wait, we have the risk of violating the dead donor rule. If we wait too long, we realize now, because we waited till the circulation had stopped now in this DCD format of donation, that these organs were now deteriorating, that there was no flow or blood flow or oxygen to, say, the liver. So when we removed the liver to go ahead and transplant, that there had been a significant time where there was no blood flow. So we wanted to make sure that we were recovering organs fast enough to make sure that they were transplantable, but not too fast where we were violating the dead donor rule. The controversies still exist, not just 2006 when we started this, but in fact questions arise in the public domain, where the Fifth Estate created a TV episode called Dead Enough. And in fact, this has gone on for generations, in fact. maybe people are familiar with the term dead ringers. People have always been worried about this timing of when you're dead. Not for organ donation in the past, but whether to bury someone. And there was actually a bell left with access within the coffin just in case they got it wrong. So in fact, this was a time to explore, and that's where our DPIC program, our Determination of Death Practices in Intensive Care, came together in 2007 to kind of reflect and try to identify where we might develop more trust and standards of practice and how we determine death in the intensive care unit. We reviewed literature to see how people were determining death across countries, especially those that did DCD donation. We found a lot of variability. We surveyed intensive care physicians in Canada to see how they were determining death, and in fact we found a lot of variability. And we reviewed a concept called autoresuscitation. I'll describe that a little bit more. So when we look at circulation stopping after a withdrawal of life-sustaining therapy, we really want to know the point at time when circulation stops, but to make sure that it doesn't come back. Now we know that if there's an event, a trauma or a car accident, that we'll do everything we can to resuscitate like CPR. But there is a point where even CPR cannot resuscitate somebody, and that would be irreversible. Or in the intensive care unit, we may choose with a person's own intent or a family's best wishes to say, listen, you can remove them from a ventilator or their life support, and please do not resuscitate with any intervention and let them pass away. But what people were worried about was actually, this slide for some reason isn't coming out at all, but what people are worried about is the event where resuscitation may spontaneously occur after withdrawal or declaration of death. And this is what worried transplanters and organ donation physicians alike, that was there a possibility after we withdrew life-sustaining therapies, declared someone dead by circulatory criteria, meaning there was no pulse, for example, could that pulse come back on their own? And if it did, and they were already in the process of organ donation, could that violate the dead donor rule? Well, in fact, when we did a systematic review of autoresuscitation, we did see that there were case reports of people documenting that pulses came back. What we found out was that all of those reports were after CPR themselves, which is not how organ donation works. They don't receive CPR. So there was something about the CPR event. And in fact, that's been coined a separate term called the Lazarus phenomenon. And in fact, there are many cases describing spontaneous return of circulation after CPR has been stopped and someone's been declared dead. And that's probably related to some physiology of the actual resuscitation that occurs, like CPR or the drugs we give, like adrenaline. So we wanted to separate Lazarus phenomena and look at autoresuscitation itself. Now to do that, we actually have to watch people die in the ICU and keep monitors on. And you can imagine that in intensive care unit, when you make a decision to limit therapies and withdraw life-sustaining therapies, it's a very emotional time. That the intent is to let families participate in their loved ones' end-of-life care. For the medical personnel, nurses, respiratory therapists, ICU doctors to kind of step away, let family be with their loved one. And here we were proposing that actually we were wanting to look at how people declare death, whether someone was really dead at a given time, and keep all the monitors on to actually monitor what they were doing at the end of life care. And in fact, many people said we couldn't do it. The people in the ICU said you shouldn't do it. But with a lot of support from a lot of strong people that believed in this question, we were able to do some pilot work to prove that actually intensive care, end-of-life care wasn't impacted by this sort of work, and the question was important enough that we carried on. So from that pilot study, we came to the CNTRP in its infancy and said, this is an important study that will enhance the safety and trust in DCD donation. And at the time, we were only doing this in Ontario, and we felt that if people saw that we were exploring questions that were important to them, that we could build trust and hopefully manage to do DCD across the country. Our primary research question was really observational, to look at the natural history of physiologic function, meaning how the heart stops, how the pulse stops, how the breathing stops, how oxygen levels drop. After we plan to withdraw life-sustaining therapies, usually this means drugs like adrenaline. This means the ventilator that keeps them breathing, and other drugs that sustain life. Our primary objective was to really look at whether autoresuscitation, the spontaneous resumption of circulation, really occurs after the declaration of death in an intensive care unit. Were we at risk of violating the dead donor rule if these individuals were going forward with donation? We had lots of secondary questions, but one of them really was to determine how quickly people were dying after the withdrawal of life-sustaining therapies. As you might recall, I mentioned in DCD, in determination of circulatory death, because we're waiting to determine death by the absence of pulse, there's a period where there's poor or no circulation to those organs. So if we could predict which people were dying faster, they may be more eligible for organ donation, and that would help the transplant surgeons identify which patients would be most suitable to donate. So we wanted a prospective observational study of ICU patients. We were collecting their physiologic waveform data at the bedside, keeping those monitors on, like arterial blood pressure, which is the pulse, the ECG, which measures the activity of the heart, the oxygen saturations, which helps us identify how much oxygen is in the blood. And we wanted to look at 500 patients in 14 ICUs so that we got a good spread across the country, because we recognized people might be dying, or the practice of withdrawal life-sustaining therapies may be different in different communities. And so this is a graphic of what we did. You know, the family would talk to the medical team, and there would be consensual decision that their loved one did not have a significant hope for recovery, and that they were going to go for withdrawal of life-sustaining therapies to allow for comfort care measures. Then a coordinator would probably come in from the organ donation system and ask whether donation might be an opportunity. It's then our research coordinator came in to ask for participation in the study, to leave monitors on. This is where initially people were very reluctant to let us in. We did some work with some key people in some key ICUs to prove that this was safe, that didn't impact end-of-life care, didn't impact donation. And because we were allowed to do that, our coordinators continued to go through that, and the research ethics boards felt very strongly about this. There's an active withdrawal of life-sustaining therapies, as I mentioned, taking away the ventilator, for example. The point of death where circulation stops, and then the point where a physician comes to declare. And what we decided was to keep the monitors on for this entire period, including 30 minutes after the declaration. That we felt gave us enough time to see if autoresuscitation would occur, this spontaneous resumption of any circulation activity, a blip on that waveform, arterial light or pulse, to see if there was a response there. And what we did is we wanted to capture all this information and analyze it. Since then, starting 3 or 4 years ago, we've had a number of successes. We've closed the study after 3 years, and immense help from the CNTRP and Project 2 collaborators. We had a 94% consent rate over the 3 years. You can imagine that asking a family at this heartbreaking time where they're grieving to consent in research, one would assume they would just say no. But in fact, for most ICU intensive care studies, when we ask them in stressful times, very few studies at the end of life where we're asking them, but before that, consent rates are only about 30%. And so we were very surprised that people wanted to participate. We think, in fact, they wanted to participate because they felt strongly about organ donation in the process, and they wanted to help in some way to make things better and easier for other people to donate. So we're very proud of that. We wanted 500 patients initially, and in fact what we found is that we've recruited over 600 patients. We wanted 14 sites to start, and in fact we have 20 sites that we recruited, not only in Canada, but we spread to other countries like the Czech Republic, the Netherlands, and the UK. We're also proud of how much information we collected. Not only are we collecting the waveforms and the monitors, but we were able to collect protocol deviations, demographic patients of the patients who were dying, and in fact these aren't just for our study. Now we have a whole pool of patients that may have been eligible for organ donation but might not have been asked, or if they were asked, they may have said no. We can look at what they looked at, why they said no. We have a ton of information on how withdrawal of life-sustaining therapies was done, and in fact if we look back we might see that it may impact whether they were the best donors they could be. If they donated, and if they didn't, maybe there were interventions at this time that may have made them a donor. Specifically, we looked at the declaration of death, who declared death, how the tests were done, how long they waited before they went for donation or not, and in the process specifically around that. So we're very happy that we're being able to collect all the data, and that's what we're doing now. We're cleaning the data. Our primary objective was to see if anybody actually saw autoresuscitation, and in fact that's what we're analyzing now, to describe the events and go from there. This is an example of the waveform viewer. So we've got miles and miles of this data electronically uploaded to a server. On the top one, I think you can see my marker. It's an arterial blood pressure. That's what we call the pulse. The electrocardiogram, the activity of the heart, and the oxygen levels, the saturation. And we can flow from early time all the way down to where declaration may have been. Right when we get to the cessation of physiologic function, you can see the pulse, a blip, and then the pulse start to diminish all the way till we get to flat line. So I think this is going to be very helpful information for us to inform the public on how death occurs, as importantly, the donation physicians at the bedside to estimate how and when to declare death and try to objectify who would be an appropriate donor. Now, our job here is not to actually define death. I think the concept of death has religious, spiritual, cultural aspects to it that we don't want to interfere with, but I think what we want to do is create an operational definition of death. And I think the information we've gathered, we can't give you a lot of it now, but I think within the year we'll be looking at publishing the data to try to kind of inform the circulatory dying sequences and what tests are necessary to ensure someone has died and is safe to move on for donation. In summary, what does death look like in the ICU? Does autoresuscitation actually exist? And how is this going to impact donation? Okay, so I'll move on. And so what I'd like to do is kind of go to the next thing I'd want people to take home is collaboration is key. I showed our 5 key core, people that I work with, our team, but there's more to this. And first, I'd like to acknowledge our patient and family partners. Heather Talbot had a son who was a donor in 2009, and Don, the picture on the left with his grandchild and wife, had a heart transplant a few years back. These individuals are key to making sure that we're answering the right question and doing it respectfully. I can't tell you how many times Heather has come to us when we've been worried about asking a question saying, "Are you kidding me? You should ask this question because that's what's important to me." And I think this has been extremely helpful to make sure as we reflect on the study we've done and we start asking more questions from the work we're doing. And I can see Alvin asking, what's next? This is who's helping us. You can see Lindsay's name on here as, amongst other people. We've got a huge group of intensive care physicians, social workers, ethicists, lawyers, et cetera, neurologists that have now come on board to help us ask and answer these questions. We've spread out from Canada to have some great collaborators in the Netherlands, United Kingdom, and Czech Republic. And what I do is inspire you that when you make one connection, don't worry about them asking new questions or spreading you too thin, that in fact, one person leads to the next person. And we are constantly growing because, and Lindsay's a great example, in fact, that when you find good people, that the connections and questions that come out of it are inspiring and make this worth it. It's really fun to keep going with the group we've gotten. I'll highlight a couple of the key sub-projects that we've been involved in, just so you get a flavor of our primary study leading to many, many secondary objectives. Jason Shaheen is a lead out of Montreal, and I mentioned the prediction of time to death. There have been some tools to determine if someone after withdrawal of life-sustaining therapy, once you remove all the things that are keeping them alive, how quickly will they die? For example, kidneys, the surgeons say, listen, if it takes longer than 2 hours, the blood flow is not good enough and we're not going to transplant. Liver, sometimes they say half an hour, sometimes they say hour. So we'd like to make sure that we're giving people the opportunity and the information about how likely they're going to be a donor, to bring in transplant teams only when we think they're likely to be a donor, meaning dying within 2 hours. So we've got a whole wealth of information, not only from the demographic data, the drugs are on, how the withdrawal was done, what was stopped first, or whether everything was stopped altogether, and now the physiologic waveform data. So it's going to be very exciting. We've already got some publications started to explore this avenue, so we're very excited about that. We're looking at new research avenues when we look at predicting time to death. Andrew Seeley is an adult intensivist, and his area of study is looking at waveform variability. So if you can imagine a heart rate being constant, actually for you and me is a very bad sign, because if I get stressed right now, my heart rate is higher. And in fact, the theory is that when you lose stress in your system, that it's impending badness, whether it's the risk of infection or with a fetal infant in a womb. When you see less heart rate variability, in fact, the obstetrician is worried about that baby and wants to take them out. So we had a thought of looking at all these waveforms and looking at variability. And what Andrew Seeley does is processes those waveforms and creates a complexity score. If you're more variable, you're more complex. And in fact, what we're finding is that the red line is more complex, that if you have more variability, meaning it's normal, you actually have a longer time to death. And that's this red line, where people with higher variability, less complex, actually took almost 7 hours to die, where a patient that seemed about the same but had less variability, being more static prior to death, only took 7 minutes to die. So we're looking at new ways to examine the data to try to answer the same questions. We're not just looking at the technology side and the physiologic waveforms, but Jennifer Chandler and Lindsay works with her, and Vanessa Grubin works with her, looking at the qualitative aspects. We have families now that we've asked whether we could interview them to see how they managed to cope with the ask of participating in research, how they coped with the ask of donation, whether they said yes or no, and how that impacted their end-of-life situation. And so we've done almost 20 interviews. We probably have 5 to 10 more. And I think from the social sciences aspect, the legal aspect, and the ethics aspect, there are many questions that we're set to answer, and we're really excited about that. We've already published some that relate to, this interesting area of end-of-life care research. A question that has expanded from the work we've done looking at circulatory death and when the pulse stops is really, we've appreciated that actually what people are worried about now is not the pulse stopping, but really how that correlates to what the brain is doing. People are worried that people are awake or aware or conscious potentially during end-of-life processes, the withdrawal process, life-sustaining therapy processes, or potentially even during the donation process. And so we started collecting information of electrographic information of the brain and blood flow of the brain. This is in pilot form. Again, people said we couldn't do it. It would be unethical to add monitoring to a patient during end-of-life care and comfort care measures, but in fact in London, Ontario, many families quickly said yes to this aspect of research during the dying process for their family members. And I think this again goes to show two things: collaborating with some experts in this area, which they have in London, and not saying no before you ask. I think these are important things. We've definitely be able to collect information, and this is one of the areas where we look for ongoing work. So let me give you a couple of examples of ongoing work. How our first question is now actually blossomed into many other questions. I don't have time to go through them all, but we had a planning meeting in Trumlaw. I know many of you were there, and prior to the bigger group meeting, and I do have pictures of many of you dancing on the dance floor, some of you actually dancing on the bar. So I'll keep that for future when you then apply for CIHR funding. It may help your applications. We had a meeting for 2 days before that of the DPART collaborators, and we brought people from the Czech Republic, the Netherlands, the UK, our Canadian collaborators, and you could see David there in the middle there, always looking very dapper. But we had our family reps, we had trainees there, we had intensive care doctors there, primary research, and clinicians. And I think it's an example of where collaboration takes you. One of the things that we want to explore from here is, as I just mentioned, a DPART-N, correlating the cessation of circulatory function and what that means for the brain. Does the brain function stop minutes ahead of time, hours ahead of time? Is there a possibility that there's activity after circulation stops? Is there some amount of oxygen and sugar and blood flow that's maintained? Is there an auto-resuscitation for the brain as much as it is for the circulation? That I think we can expand our work there with more funding, more support from the CNTRP. So we're excited to look forward to that. We look at moving from being safe and transparent about declaration of death and making sure that there's trust in the system. But in fact, the amount of information we have of how and when someone is dying and then becomes a donor, it's not a black and white time. In fact, there's a a pattern to how people die, as far as, do their blood pressure suddenly drop, as you see here, and then continue at a very low pressure? Or would somebody actually continue at a very high pressure and then at the very last minute drop? Now that might affect how successful that donor might be able to have recovered organs, or the transplant, or the graft survival. Same thing for oxygen saturations. Do oxygen saturations fall very quickly, or do they dwindle, or is there a sudden drop right at the end before the determination of death? I think we have lots of data to try to examine the hemodynamic patterns, not just when, but how someone dies in the intensive care unit, as far as their blood pressures and their oxygen levels. That might give us a clue of how well these grafts are transplanted. That's kidney, liver, lung, heart, for example. And so that's D-Part Go, another question we're looking at. And then CNTRP already has connections with a group called Evado out of Montreal, looking at artificial intelligence and machine learning. And I think we have reams and reams of data. I think Alvin's question, I can see, we have a very large database. And I think we're looking to explore with this group to say, can we create algorithms to explore questions we haven't even asked, to see if there are patterns that are being identified by machine learning, that then we could go back and see if it impacts graft outcomes, time to death, even withdrawal patterns, autoresuscitation, for example. So I think our eyes are opening, and it's about collaborating, and it's about asking those first questions. And last, I'll close with the opportunities within CNTRP. I think we've moved with our collaboration and our success with the D-Part study, moving from donation being project 2 out of 7 to really being a pillar within the CNTRP and a national, and from here, international research collaboration, where we look at BMT blood and hematopoietic stem cells transplant, solid organ transplant, and donation in critical care, creating intertwined mesh as a pillar to improving donation and transplant, and really moving donation as the right and a good thing to do and a feel-good project to actually creating a body of science in donation, which is in its infancy. And I think the CNTRP is going to get us there. So I hope for everyone you took something to inspire you, that if you have questions and you've started things, that keep at it and do it. Don't give up. That in fact it's about collaborating and not doing this on your own. I don't have a master's, I don't have a PhD, and I envy you guys who do, but I use the people around me to collaborate, that we did this together, and I'm really proud of that, and that from here, that one question has led into so many more questions that will impact patients at the bedside, whether it's on the transplant side or on the donation side, and I think we have to look at it that way. And I'm really happy that we got to spend some time this afternoon, and I'll open it up to 10 minutes of questions if you have them. Thanks very much.